You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil, and today we're joined by Dr. Jarratt Pytell. He's an assistant professor of medicine at the University of Colorado School of Medicine and an addiction medicine clinician at the Denver Health Hospital. He's an investigator who focuses on the primary care treatment of substance use disorders. So today we're going to talk about his commentary piece from the May-June 2025 issue of the Journal of Addiction Medicine. It's entitled Post Void Residuals, Medications for Opioid Use Disorder, Patient Outcomes, and How Not to Get Fooled by Urine Toxicology Results. So, Dr. Pytell, welcome to the podcast, and we would love to hear you talk a little bit about yourself.
Yeah, absolutely. So, I began my internal medicine residency in 2015 in Baltimore, and I was really fortunate to train at a lovely and spectacular primary care clinic called the Comprehensive Care Clinic that had been doing office-based addiction treatment probably since they were first allowed to, and the waiver for buprenorphine was a thing. And it was also a place where they did comprehensive HIV primary care. So it was just a group of faculty who were really dedicated to taking care of the whole patient and doing it all within the primary care context. And so I completed my internal medicine training in my longitudinal clinic with them. That was a really defining moment in my career, because at the same time, this was 2015 in Baltimore, the fentanyl overdose epidemic was taking off, and it just seemed that for not every single patient, for many patients, if you just kind of peeled back the onion a little bit to understand like what it was that they were coming in to have addressed, substance use was somewhere in there contributing to it. So I also knew that in my background as a former teacher and math major, I was really interested in research. And so after my residency, I had just another spectacular opportunity to stay on at the clinic and complete be the first addiction medicine fellow, and combined an addiction medicine fellowship with a general internal medicine fellowship, where I spent 4 years honing my skills in addiction medicine, and again being exposed to some really spectacular faculty, while also learning robust health services methodology. And that put me on my kind of current trajectory as a clinician and investigator, working at the intersection of the primary care treatment of substance use disorders broadly and opioid use disorder in particular.
Fantastic. Well, it's great to have you here on the podcast. And I wanted to start talking about something that we had briefly discussed earlier, and that is urine drug screen results. So these are often the main outcome metric that clinicians are using, which gives the perception of objectivity. But based on the cutoffs that are used, it can sway what a positive or negative outcome may be. So in light of this concept, could you please discuss how this makes the urine drug screen more of a subjective measure and what that means for addiction treatment?
Sure. And in our article, and this is I have to give credit where it's due to Dr. Feline, came up with this kind of term of the illusion of objectivity. Because what we saw in that Peterson paper was that by, just tinkering a little bit with what we consider negative, we can come to different conclusions about the effectiveness of a treatment. So in the Peterson article, it was an excellent article, and they did a really great job of depicting this, that depending on the level that you use to determine if a urine drug test was negative for an opioid, changed whether there was a significant difference between the two groups. One was the sublingual buprenorphine, and the other group was the extended release buprenorphine. And what they found, using the lower limit of quantification, which is essentially like the minimum amount of the drug or its metabolites that can be present in the urine to determine if something is positive. When they used that lower limit of quantification, there was no difference between the groups, and with the main outcome being negative urine drug tests. And then as they increased the cutoff to maybe those levels that might be more relevant in kind of clinical medicine, the results then, the difference between the groups became bigger, and those differences being statistically significant. And so that's kind of what we took and ran with, was this idea that these urine drug tests, we feel and clinically think that they are telling us the truth. The drug test is positive or the drug test is negative. But in reality, what is true and what is what is positive and what is negative is sensitive to these arbitrary cutoffs of our drug tests. And so that's kind of what we, wanted to kind of just take what this article by Peterson really gave us an opportunity to do, is to say, okay, well, how much weight should we be placing on these urine drug tests, particularly in clinical practice, when determining if a treatment is effective, if a patient is getting better. Now, this doesn't necessarily translate to clinical trials, of which this paper was a secondary analysis of that randomized clinical control trial, because the FDA and the European Medical Association, the EMA, they set the goalposts and they kind of tell people. But it gave us an opportunity to ask and to reflect on what role these tests should have in clinical practice, and to maybe take a moment to question whether or not they're the best test or the best outcome to be using in primary care or just general outpatient addiction treatment.
Great. Now, my next question builds on this discussion. Could you discuss how it can be clinically useful to question patients more directly about their substance use, and shifting the focus from discussing urine drug screen results, even though those results may be helpful?
Right, and I don't think we would argue or want to argue that urine drug or toxicology testing in general, urine drug toxicology in particular, has no role in treatment. I think it definitely does have a role in treatment. It's a test like any other that should be ordered to ask a specific question, and its results just need to be interpreted in light of the sensitivity, specificity, and limitations of the test. So you're right, and I completely agree that urine drug toxicology is important and should be a part of practice, just like every other test that we order to help evaluate a patient under our care. But where does this come into? Is it urine drug tests tell us if there's a metabolite or a substance in the urine above a certain threshold. But we know that is not the same thing as remission or recovery from a substance use disorder, opioid use disorder specifically in this case. It might be an important measure for some patients, that they need to reach complete abstinence and not use drugs anymore in order to reach that end point of recovery or remission. But not all. And many patients whose goals for treatment are not necessarily abstinence, but maybe harm reduction, it then really doesn't give us any information on if they're meeting their goals. And how do we then determine if a patient is doing well? we ask them, right? We have a conversation and we talk with them about how the treatment is impacting their control over their substance use, and if it is reducing the associated harms. And that sort of rich, nuanced information about a person's recovery, unfortunately, just can't be determined by a positive or negative urine drug test. It needs to happen by directly asking patients about their experience, about their symptoms, and doing it in a systematic way over time.
Very good. And we had previously talked about tapping into a patient's motivations. If we're not going to focus on drug tests, what are we going to focus on? Do you think it's beneficial to steer away from lab results when trying to ascertain and tap into a patient's motivations?
And I think you hit the nail on the head, is that, we have to treat the patient in front of us and have an individualized approach to care, which could potentially mean an individualized approach to outcomes and outcome monitoring. And I think we just need to take a moment to talk about what it is that we do currently test, and maybe how reflect a little bit about how that is not a true individualized approach, right? So we talked about urine toxicology. The other thing that we often talk about is adherence to medications or medication retention. And I think in our previous work, we've shown that many people initiate treatment with no desire to be on a medication long term. And some patients have no desire to be on any medication. Now, that does not mean that we shouldn't treat them, right? It means we should still treat them, but meet them where they're at with what they're interested in. And then further, these, again, somewhat arbitrary cutouts about what is a positive outcome in terms of retention at 90 or 180 days, again, just reflects, this not measuring the things that matters most to patients. And then I'll just take even we design our systems, our healthcare systems, and our treatment and our approach to care to get the outcomes. And if we are focused on urine toxicology, then all of our systems are going to be designed to get that outcome of a negative urine, including, which is why patients often will, might falsify their urine drug test in order to give an outcome that we want, because they're afraid of what will happen if they have a positive. So I think we just need to take a step back and say, we design our systems to obtain the outcomes that we currently measure, and our systems are designed about it. So if we refocus our outcome monitoring to things that matter to the patient, it will force us to think about how to design our systems and our approach to care to get the outcomes that we are currently monitoring.
Okay. So I also wanted to see if you had any tips for engaging patients. Maybe discussing the need to focus on developing a therapeutic alliance with the patient, especially patients who may have a fear about how the urine drug screen results are going to affect their treatment.
Right. Okay. Thank you. Yeah. And I think, developing a rapport, a therapeutic alliance with patients is key. And I think, starting out with a discussion about what the patient's goals are, so that you can design your treatment and your therapies and your outcome monitoring to help those patients meet those goals. And I do think from a patient perspective, it would probably be not so beneficial if a patient tells us that their goal is to potentially reduce the harms of drug use, but the only thing that we are focusing on and asking them about and testing for is a urine drug toxicology that doesn't really reflect necessarily what their goals are. And so I think that's point number one. And then point number two is always educating patients and letting them be a part of the team, right? Educate them about what the test is, if you are going to use a urine drug test, why are you ordering it, and what you're going to do with the information. I think very often for patients, these tests are a high stakes test, real or imagined. they might feel that, the drug test is there to surveil and punish if it's positive, which could have implications on their access to treatment, how much medication they're getting, how many times they have to come in. And so I think it's always important to, as with every test that we do and we order in care, educating the patient about why we're ordering that test and what we are going to do with that information. I also, just as a general tool, always ask a patient ahead of time what they expect to find on the urine drug test so that there's no surprises. And it gives an opportunity, again, just to say that, I care about you. This is something that I'm doing for this reason, and it will be helpful if you tell me ahead of time what it's going to be. And quite honestly, over a long enough period of treatment, absent any state regulations or local clinic policies, urine drug tests almost don't carry meaning anymore because you can just trust the patient and what they're saying over time.
Yeah, well, the atmosphere can often feel punitive to the patient, and I feel that many patients, including some that I've treated, are on guard when their lab results are at the center of their treatment. Many of them feel like the clinical encounter may become punitive if they happen to test positive, and I think that leads a lot of patients away. It leads a lot of them to stress about the lab results. And I think instead we should stress open communication with our patients and having them connect to their provider. So can you comment on how you can perhaps foster that trust with your patients?
That's so true. And, I think it's the therapeutic alliance too. It's just like, does the patient believe that we are helping them meet their goals? Or are we trying to get to some arbitrary cutoff of positive and negative urine drug tests? And certainly, again, there are patients that I've had, and I'm sure all of us that could think about, who love the urine drug test as a almost like a biofeedback metric that helps them prove to themselves and gives them this this feeling of objectivity around absence that the urine drug tests could play a role in long-term therapeutic monitoring. But to say that is the only way to monitor a patient and to think about helping them reach their goals is through a urine drug test with all the limitations that I think Peterson kind of pointed out, doesn't help us meet our patients where they're at and doesn't help us provide a patient-centered, individualized approach to care.
Great. Now, the final point that I wanted to discuss is whether other measures might be useful. We've talked about urine drug screens and some of the pitfalls of using a urine drug screen as your only measure, but can you talk about some other measures that clinicians might focus on, such as the BAM or the T?
Right. And I think as with urine drug toxicology and the other outcomes that we are routinely monitoring, like medication adherence, like retention and care, at the population and clinic level, we monitor things like infection, overdose death, right? Those are still, relevant and important metrics that we should not ignore, and we should continue to assess. But we should also think about how to directly ask patients about their recovery, about their ability to control their use to reduce harm, and doing that in a rigorous way over time. And we have a model for this for any of, for those of us who practice primary care and think about monitoring patients with depression and using a standardized assessment like the PHQ-9. These same assessments exist for the concept to help monitor and track people over time with substance use disorder. Now, there isn't one best measure, right? There isn't one universally agreed upon measure, and I think ongoing work and research is needed to find the measure or measures that can be used at different phases of treatment, including early in treatment in the first couple of weeks when the person's stabilizing, to those kind of periods of early remission. Think after a medication's been titrated to an effective dose and a patient is working on multiple domains of their life, to long-term sustained remission. Once a patient has reached a period of stability, there's probably measures that we can use at those different times. And I think we need to invest money and time to research and give clinicians the tools to follow patients over time. But to give you an idea of what that might look like, early in treatment, there's several different validated measures to assess a patient's cravings, right? A really key determinant when we're titrating a medication like buprenorphine or methadone in the context of opioid treatment programs to an effective dose. And then once a patient might be at an effective dose, that doesn't necessarily mean they're in recovery. And we could think about measures such as the Brief Addiction Monitor, or the BAM, the TEA, which is called the Treatment Effectiveness Assessment. Another measure out there that was developed actually with a lot of buy-in from people who use drugs was the SURE, the SURE, the Substance Use Recovery Evaluator. And these are, and then I'll just also mention the PROMISE measures, right, which were a huge undertaking to develop these validated assessments on these different constructs on information that we can only get by directly asking patients. But what it does do is it asks patients about a construct of recovery, and it can be done in a rigorous manner over time using a validated assessment, and can be useful in clinical care at the individual patient level to help identify if a patient is improving or if they're retreating from recovery, and offer an early intervention or offer continued tailored treatment to help them meet their goals. And so these sorts of measures, these patient-reported outcome measures, as they're routine in with other chronic conditions, I strongly believe can help us when we're caring for patients with opioid use disorder. And again, focusing on the thing that matters maybe most to patients, which is not the results of a urine drug test, but their progress towards recovery.
Fantastic. Well, are there any final points that you would like to make?
No, I just do think, though, that by refocusing our outcomes on the outcomes that matter to patients, it could give us an opportunity to potentially improve our healthcare systems and meet the needs of patients who right now, just like I feel, are not being met. And I think it's reflective in our poor retention in care. And it goes back to the public health axiom of what gets measured gets changed. Mm-hmm. And if we now focus our outcomes and make it a primary outcome of improving the recovery of a patient, right? Helping them reach this recovery, which is tough, right? Because recovery is multidimensional. It means different things to different people. But I don't think we should be afraid of that challenge, right? I mean, the search for a simple one number or one outcome like for a urine drug test, I think is going to keep us offering the same old thing without actually asking ourselves, how can we actually change how we're offering treatment and developing our systems to actually help patients get better.
That's great, and I think that should resonate with any clinician. So Dr. Pytell, it's been a great pleasure having you on the podcast. For our audience, Dr. Pytell's article will be in the May-June 2025 issue of the Journal of Addiction Medicine. Again, it's entitled Post Void Residuals, Medications for Opioid Use Disorder, Patient Outcomes, and How Not to Get Fooled by Urine Toxicology Results.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.